In this presentation, we'll be discussing metastatic tumors invading in the orbit. Let's start with adult metastatic tumors. Orbital metastases are an infrequent cause of proptosis and are much less common than metastasis to the choroid. If the orbit is the site of initial manifestation of the tumor, the ophthalmologist may be the first specialist to see the patient. In approximate order of frequency, the most common primary sites are breast, which is up to 70%, bronchus, prostate, skin, where melanoma is the most frequent cause, gastrointestinal tract, and then kidney. Diagnosis is based on signs and investigations. Signs are associated with a range of tumors that can spread to the orbit. Presentation can take a variety of forms. Dystopia and proptosis are the most common features. Infiltration of the orbital tissue characterized by ptosis, diplopia, browny indurated periorbital skin, and a firm orbit with resistant to manual retropulsion of the globe. Enophthalmos with serous tumors, chronic inflammation, primarily with cranial nerve involvement of 2nd, 3rd, 4th, 5th, and 6th, and only mild proptosis with orbital apex lesions. Now, investigations include CT and MRI, which typically show a non-encapsulated mass. Fine needle biopsy is useful for histological confirmation. If this fails, open biopsy may be required. A search for a primary must be carried out if the patient was not previously known to have cancer. Treatment is aimed at preserving vision and relieving pain because most patients die within a year or an average of 4 months. Radiotherapy is the mainstay of local treatment, but systemic therapy may also be of benefit. Surgical excision of the focus is occasionally carried out. Orbital exentration is usually only performed if other modalities fail to control the intolerable symptoms. Next is childhood metastatic tumors. The most common in the first one is the neuroblastoma. Now, neuroblastoma is one of the most common childhood malignancies. It arises from the neural crest-derived tissues of the sympathetic nervous system, most commonly in the abdomen, as you can see in the axial CT, which shows a tumor adjacent to the kidneys. You can see it here. And presentation is usually in the early childhood. In almost half of all the cases, the tumor is disseminated at diagnosis when it carries a very poor prognosis. Orbital metastasis can be bilateral and typically presents with an abrupt onset of proptosis accompanied by superior orbital mass and lid ecchymosis. As you can see in the picture here, there is ecchymosis in both the eye and there is ptosis in one of the eye. Now, next is the myeloid sarcoma. Myeloid sarcoma or granulocytic sarcoma is a solid tumor composed of malignant cells of myeloid origin. Because of the tumor may exhibit a characteristic green color, it was formerly referred to as chloroma. Myeloid sarcoma may occur as a manifestation of established myeloid leukemia, or it may precede the disease. Orbital involvement usually presents at about age 7 years with a rapid onset of proptosis, sometimes bilateral, and can be associated with ecchymosis and lid edema. When orbital involvement precedes systemic leukemia, and diagnosis may be difficult. Then is the Langerhan cells histiocytosis, which is a rare group of disorders due to clonal proliferation of histiocytes. Presentations range from localized disease, usually with bone destruction, which is eosinophilic granuloma, through multifocal bone involvement to a fulminant systemic disease. Soft tissues are less commonly involved, but cutaneous and visceral lesions may occur. Orbital involvement consists of unilateral or bilateral osteolytic lesions, and soft tissue involvement, typically in the supratemporal quadrant. As you can see here in the left eye, there is dystopia and a little bit of proptosis. Patients with a solitary lesion tend to have a more benign course and respond well to treatment with local curettage and intralesional steroid injections or radiotherapy. Systemic disease has a worse prognosis. Now, another modality is orbital invasion from adjacent structures, which occurs in cases of sinus tumors. Malignant tumors of the paranasal sinuses, although rare, may invade the orbit and carry a poor prognosis unless diagnosed early. It is therefore important to be aware of both their otolaryngological and ophthalmological features. Maxillary carcinoma is by far the most common sinus tumor to invade the orbit. It is also shown in the picture here on the left side. You can see a clear-cut change in the facial features here, and it is causing facial swelling and upward dystopia. Otolaryngological manifestations include facial pain and swelling, epistaxis and nasal discharge. Ophthalmic features include upward dystopia, diplopia, and epiphora, as upward dystopia is seen in the picture. As opposed to that, ethmoidal carcinoma may cause lateral dystopia, and nasopharyngeal carcinoma may spread to the orbit through the inferior orbital fissure. Now, another modality is the bony invasion, which occurs in cases of intracranial meningiomas arising from the sphenoid ridge and may invade the orbit by direct spread and cause proptosis. Occasionally, tumors arising from the tuberculum cilia or olfactory groove may invade the orbit through the superior orbital fissure or the optic canal. Next is the fibrous dysplasia, which is a disorder in which fibrous tissue develop instead of normal bone, leading to weakening and a mass effect, as it is shown in the CT scan, where there is the fibrous dysplasia of the orbit, and you can see the clear difference between the two orbits. This is the fibrous dysplasia here, and there is the involvement of the floor and the medial wall in this coronal section. Now, within the orbital region, this may cause facial asymmetry, proptosis and dystopia, and visual loss. Most orbital disease is due to the monostotic form. Polyostotic disease is associated with endocrine disorders and cutaneous pigmentation, which is McCune-Albright syndrome, which occurs in 10% of the cases. Now, the next modality is the orbital invasion from eyelid, conjunctiva, and intraocular tumors. Orbital invasion may occur from eyelid malignancies such as basal cell carcinoma, squamous cell carcinoma, or sebaceous gland carcinoma, from conjunctival tumors, for example, melanoma. As you can see in the top picture, this is the invasion from a melanoma here, and from the intraocular tumors such as choroidal melanoma or retinoblastoma, as you can see in the bottom pictures. This is the invasion from the retinoblastoma, which is quite rare to see. So if you like the lecture, please click on the like button and subscribe to the channel. Thank you all.